next speaker, Dr. Rahul Mangla. She'll be speaking on anatomic and functional outcomes of arch-shaped SRF in wet and wet AMD.
Good morning, sir. Today I'll be presenting on anatomical and functional outcomes of arch-shaped SRF in wet AMD. So very often in clinics we see these type of chronic CNVMs and we are confused whether to leave them alone or to treat them. So in 2016, Fanikin et al. Came up with the article bridge-shaped, arch-shaped SRF in age-related macular degeneration. They defined bridge-shaped SRF as a fluid accumulation in the subretinal space which were mainly limited laterally due to the adhesion complexes between the CNVM and neurosensory retina. They went on to give 3 monthly ranibizumab injections followed by PRN dosing. They concluded that mainly there were type 2 fibrotic CNVMs and there was improvement in the SRF resolution after 3 monthly intravitreal ranibizumab, but resulting in poor visual outcomes. But the study lacked baseline predictive characteristics of CNVM, which could prevent the development of bridge-shaped SRF and help us in achieving good visual outcomes. So we did this study with the aim of completing out the factors of the bridge arch-shaped SRF on OCT in wet ARMD and to study the anatomical and functional outcomes. So we took on our OCT-based data, the neovascular AMD, out of which we took predominantly scarred CNVMs, and we took out the bridge arch-shaped SRF, and we studied the clinical and OCT profile of the before the development of arch-shaped SRF, at the time of development, and last follow-up visit. We also defined the bridge arch-shaped SRF as a bow-shaped SRF with neurosensory detachment. We documented best corrected visual acuity at presentation, at development of bridge arch-shaped SRF, and at the final visit. We also documented treatment received before development of SRF and after development of SRF. We also studied the OCT features such as level of the CNVM, whether it was a single or a multi-compartment SRF, the height of the SRF, presence of the RPE tear, and greatest linear dimension of the RPE tear. So we found that there were 821 eyes with the neovascular AMD, in which 623 eyes were predominantly scarred CNVMs, out of which the 24 eyes had bridge arch-shaped SRF. So we saw that the bridge arch-shaped SRF, the mean visual acuity was 30 letters, while the OCT features at the time of presence of bridge arch-shaped SRF mainly was type 2 CNVM, that is accounting to 75%, and type 1 CNVM was found to be 25%. We also saw that the presence of RPE tear was 33%. And in the 14 eyes where we had the OCT prior to the development of bridge arc-shaped SRF, we found that the mean visual acuity was more, that is 53 letters, and type 1 CNVM was more, that is 79%, while the type 2 CNVM was just 21%. We also found that the mean time interval for the development of bridge arc-shaped SRF was 22 months. So we found that the time of development of the bridge arc-shaped SRF was 22 months. Also that the vision had dropped from 53 letters to 30 letters, and there was a conversion of type 1 CNVM to type 2 CNVM. So in a case series, we found that at a gap of 15 months, the type 1 CNVM in picture A had changed to type 2 CNVM with the arc-shaped SRF with adhesion complexes. So in our study, the 77% of patients received intravitreal anti-VEGFs. Mean number of injections received were 4. And there was a complete resolution of SRF at the end of 1 month only in the 68 eyes, while the 82% of eyes had the complete resolution of SRF at 3 months. Also, there was only 4% of patients where there was improvement of more than 5 ETDRS letters, while the 60% of the eyes at the final visual acuity was worsened. There was also recurrence of the SRF in 18% of eyes. In this patient also, she was an 81-year-old. The patient had bridge-shaped SRF and type 2 CNVM with 1 brolucizumab injection. We did achieve the anatomical closure, but there was no visual acuity improvement. In 22 eyes, there were where we had the last follow-up details. We found that the mean time interval from bridge arch-shaped SRF to final visit was 26 months, and at the final visit, mean visual acuity was 24 letters. So we found that the bridge shaped SRF could be from type 1, it changed from type 1 CNVM to type 2 CNVM because of maybe RP breach, RP tear, inadequate treatment, and these release the profibrotic factors leading to submacular scarring and fibrosis, and thus leading to bridge arch-shaped SRF. So we concluded that aggressive treatment is required to prevent the bridge arch-shaped SRF. Also, 68% had complete resolution at 1 month, 82% eyes had complete resolution at 3 months. There was 7 ETDRS letter reduction in visual acuity, and the patients were treated on PRN dosing. So aggressive treatment with monthly injections is needed to prevent the vision loss. The weakness of the study was that it was a retrospective study, it was a small cohort, and no comparative groups we had, no comparison of response to different anti-VEGFs was seen. The strengths were that it provided characteristics of the CNVM prior to bridge arch-shaped SRF and pathogenesis and final functional outcomes of bridge arch-shaped SRF. So to conclude, predominantly scarred type 2 CNVM with subretinal fibrosis and adhesion complexes between neurosensory retina and CNVM RPA complex, their presence suggested fibrotic enlargement leading to poor visual outcomes. Thank you.
Thank you. So appearance of this R-shaped SRF, that is a bad omen.
Yes, sir.
I mean, the results, because mainly fibrovascular tissue is there, and vision may not be achieved.
Yes.
These patients, I think, should be counseled very wisely, because they are the people who can cause a ruckus because vision is not improving.
Yes.
We are saying the treatment is the things are under control, and these are the people. And if a person is junior, he should, I think, he should refer it to senior one. Even I refer it to my colleagues, so that because visual outcome is not very good, and I may not be able to handle it. Thank you.